This conference will now be recorded.
All right, so we're going to cover chapter 22 as one of the makeup days, immunologic emergencies. Going to bring out the highlighter pen. All right, so every year, more than 50 million Americans experience an allergic reaction. This can involve an acute airway obstruction and cardiovascular collapse. All right, so this is why it's so important, epi, and stop. People are afraid to pull that trigger to give epinephrine. When you see the anaphylactic reaction, those signs and symptoms, we need to pull that trigger and get that epi on board. We'll talk more about epi in a few minutes here. Allergic reaction is an exaggerated immune response to any substance that might require epinephrine. Anaphylaxis is an extreme systemic form of an allergic reaction involving two or more body systems. Now, they say body systems, that can be cardiovascular, respiratory, integumentary, all these different systems that are going to come in, lymphatic, looking at the different systems that we have. But two systems or more that are involved make an anaphylactic reaction. Distinguish between the body's usual response to an allergen and an allergic reaction. So what we come in contact with. And even still, there are still people that can have something for a long period of time. Example would be like strawberries. Never had an allergy to strawberries in their life, and all of a sudden, bam, now they have, an allergy to strawberries when they least expect it. All right. So a little bit about some anatomy review. Remember that the immune system protects the human body from foreign substances and organisms, right? Remember that we have histamine release inside the body to help protect that. So body protection systems would include cellular immunity, which is specialized white blood cells called T cells that attack and destroy invaders. Okay. Then we have humoral immunity, which would be B cell lymphocytes, which produce antibodies. Right. So these are being released to help fight off that infection, but in turn, it's also causing our body to have a significant reaction because of this. Right, so our body releases that histamine, and we got to be able to provide a histamine blocker like Benadryl, which would be a paramedic level medication, which makes no sense to me at all, and to help block that histamine release so we can control in the system. So almost any substance can trigger the body's immune system and cause an allergic reaction. Animal bites, food, latex gloves, all right, even semen, the same thing as well. Is another one that could do it during sexual activities. So the general categories of an allergen would be like an insect bite or sting, where with medications, we look at reaction of injected medication, maybe immediate or severe, depending on when you do an injection on somebody, which is why it's very important we do the 6 rights of patient administration for medications to make sure they're not allergic to that med. Reactions to oral medications may be slower, but can also be very severe as well. Then we have plants, dust, pollen, mold, mildew, or other organic materials, and foods like shellfish, peanuts, may result in a relatively slow reaction, but also may still be quite severe. And then chemicals, so like makeup, soap, hair dye, latex, other substances like that can cause a severe reaction. So they could be anything they came in contact with. So our first thing we need to do when we get on scene for these patients is not to interrogate them what they got into. If they can't breathe in their anaphylactic reaction, is stop the reaction, get them back to a better homeostasis state, and then start asking questions afterwards what they got into. They may have their own EpiPen, or we need to drop our own Epi if we have ready check and check kits. So EpiPen is not, I don't know many services now that still carry EpiPens just because of the sheer cost. So they've gone to the ready check and inject system up to your EMT, up the paramedic that you can utilize. It's getting Epi on board. So allergens are usually harmless. However, the antibodies are a protein produced by the body in response to an antigen. Foreign substances that invade the body through the skin, the respiratory tract, and/or a gastrointestinal tract. The invasion through the skin may come from come in the form of either an injection or absorption, inhalation, or ingestion, and how we got it into our system. Right now, as we know, injection, inhalation are a lot worse. Now we're getting it directly into our lungs or directly into our vasculature that can cause a significant reaction, right? That breathing issue. So when a foreign body substance invades the body goes on alert, right? We talked about that before, right? Which initiates a series of responses. The first encounter begins as the primary response, so mainly involves the white blood cells. Remember those T cells we were talking about. The macrophages are determine if the foreign substances are allowed. Like either they can come in or no, they can't. If the body is unable to identify an invader, immune cells are then used to record the features of that substance. And then the immune cells design antibodies to match up with the antigen and inactivate it. That's how our body works. The body then develops a sensitivity through that primary response, recognizes the foreigner next time it is encountered, if something is brought to your attention to the body. The body then places specific antibodies on the basophils and the mast cells within the system. Then the chemical mediators then are produced by basophils and mast cells, which contain granules filled with powerful substance to fight off that antigen. So the granules are then released from the mast cells and activated if an antigen combines with one of the antibodies that are in your system. Degranulation is when the granules burst, releasing these contents, which launch and maintain the immune response. When this happens, your body is then going to summon more white blood cells, increase the blood flow to that area, which also can be dangerous when as well. So that it's dangerous when they are spread throughout the entire body, right? We have that significant reaction causing which type of shock? What kind of shock is anaphylaxis? Okay, exactly, distributive, as it's distributing through the entire body. So systemic effects cause that allergic anaphylactic reaction, which puts them into distributive shock, and we have to be able to treat that. So we're going to start seeing those changes as far as decrease in blood pressure, tachycardia. When we start seeing the difference, or severe respiratory distress, angioedema to the tongue, and we see those different body systems being attacked, that's when we need to hit them with the epinephrine, right? Even the simple, because if you have multiple body systems being attacked at that time, remember, that's epi, right? If you have a localized reaction, so a little bit of urticaria or a little bit of a rash, like the say on top of the forearm, with no respiratory compromise, no cardiovascular involvement, that patient does not require epi. And they feel like their throat's getting tight, they're becoming itchy, notice widespread urticaria to the body, right? Now we're starting into the epi administration. So this figure here shows a sequence of events in anaphylaxis, right? So the antigen is introduced into the body. So we'll start up here at A, up here, work our way down B, C, and D, right? So A is the antigen being introduced into the body, right? As you can see, as it's being introduced from here, coming down to B, where the antigen and antibody reaction occurs at the surface of the mast cell. This is our mast cell here, right? The mast cell chemical mediators then become released, right? So as you can see here, they're coming out and being released out into the world, or into internal world, where the specific antibody reacts with its corresponding antigen, right? So C here, going into D to the antigen, and then in E, so coming down to here, the chemical mediators then exert their effects on the end organs, whether it be the lung, which would be bronchospasm or vasoconstriction, right? The heart, decreased output and decreased coronary blood flow. Blood vessels start vasodilating and start leaking. That's where you get our hypotension. So shortness of breath, hypotension, right? And then we start seeing urticaria, edema, or pruritus on the skin. So our multiple different organs that are being attacked, all because of the initial antigen that was introduced to the body, causing these um, mast cells to then release mediators. That's what these things are here, the mediators, into the system to come in contact with the antigen, which then in turn can potentially cause different types of failure within our different organs. Right. So we have to make sure that we get to that point where we say, okay, we're starting to see some minor compromise. This is going to turn into widespread, as you can see here, to the urticaria as well. And we're going to need to administer that epinephrine on the lateral thighs. So vaccines produce against immunity against diseases, right? A little bit more about the pathophysiology stuff. So the body develops antibodies in response to the vaccines, whether it be the flu vaccine, MMR vaccine, measles, mumps, rubella, even to the COVID vaccine now, right? So the body produces an immune response to neutralize that disease. So when you're getting a vaccine, you are getting that virus introduced into your system. But when that's happening, right, it's a low amount, not enough to actually hurt you. You're still going to feel some effects. So for those of you in the class that did receive the COVID vaccine, what's the most recent vaccine we've received, right? Did you start feeling sick afterwards? That's a question to you guys.
A little bit for 2 days for one of them.
Right. So for some, like for me personally, the first vaccine wasn't that bad. The second one was a little bit worse. And then the booster shot kicked my ass. So the second one kicked your ass too. And it's something that can be very detrimental to the system. There's a visitor here in the office. All right, sorry, where was I here? So then it develops antibodies in a controlled way. So if an actual virus enters the body afterward, the virus is then identified. Antibodies produce it to kill it, right? Our killer cells. So what were our killer cells again that come out? You guys remember which ones those were? The killer ones? Remember which one those were? Which cell? We just talked about them. Anybody want to take a stab at it? Awesome, Sean, good job. T cells. Exactly. All right, so if the actual virus enters the body afterwards, remember we talked about the antibodies are produced to kill it, the secondary response or an intense response to invading the virus, to the invading virus. Acquired immunity is the administration of a vaccine which allows the body to produce antibodies without having experienced the disease at all. A natural immunity is the body's experience to the full immune response with all the effects of the disease. So you get it and you're born, and then you have natural immunity to it versus actually receiving a vaccine and getting immunity that way. So the immune system becomes hypersensitive to one or more substances during an abnormal reaction. So with an allergic reaction, the immune system reaction that occurs when a person has been previously exposed or sensitized to a substance or allergen. So here comes the topic we all want to know more about is allergic reactions versus the anaphylaxis, and when do we pull that trigger to be able to administer epinephrine? So an allergic reaction is a mild and localized reaction or a systemic reaction. With hypersensitivity being exaggerated or inappropriate allergic symptoms after coming into contact with a substance perceived by the body to be harmful. Anaphylactic events should not be mistaken for heart attacks, heat stroke, or many other conditions. So diseases related to allergies, such as allergic rhinitis, so runny nose, asthma, atopic dermatitis, all increase the potential for an anaphylactic reaction. So routes of exposure to the antigen and the time between exposures are the major factors associated with anaphylaxis. So route of exposure and time, right? The two things we got to pay attention to. Anaphylaxis is then mediated by what they call IgE antibodies. Anaphylactoid reactions does not involve the IgE antibody mediation, right? So the anaphylactoid event may occur without the patient being previously exposed to the offending agent. One more pathophysiologic response. So mast cells recognize foreign substances as a potential or potentially harmful and to release chemical mediators. So there's two types, histamine and leukotrienes. So the first one being histamine causes blood vessels in the local area to dilate and the capillaries start to leak. So your body is releasing histamine, right, to help fight off that invader. But by doing so, it's also causing significant harm to the body by causing that blood vessel dilation. Then you'll start seeing that hypotension, right? The other one is more powerful than histamine. It's caused by additional dilation and leaking. So we need to get those histamine blockers on board and getting Benadryl on board as fast as we can. So you should always have a paramedic coming for that to administer that second medication above and beyond epinephrine. Now, there may be times where the patient is so bad of anaphylactic reaction that's so bad that they may require an epinephrine drip, something that you cannot do as an advanced EMT. Getting the paramedic on board, they can administer this drip. But getting IV access will be tremendously helpful because we can start the epi drip pretty fast if they have IV in place before the body starts to swell more with that reaction, causing that edema, and you'll be able to find IV access. So the faster you can get IV access in these patients, the better. White blood cells are then called to help the area, to the area to help engulf and destroy that foreign substance. So our T cells, white blood cells, those are coming to help destroy that area, all right? To help destroy that foreign substance, I should say. And platelets then begin to aggregate. And so in most cases, this overreaction is restricted to the area involved because they start clumping together. Anaphylaxis or chemical mediators are then released, and the effect involves more than one body system. Remember, we talked about lungs, so respiratory, cardiovascular, integumentary, different systems of the body. The initial effect may be seen from release of histamines, with a secondary effect following a few hours later. Histamine release causes immediate vasodilation, right? Often presenting as flushed skin and hypotension. Increased vascular permeability, so increased leaking, resulting in angioedema, fluid secretion, and fluid loss. So we're also dehydrating them, removing their fluids, on top of vasodilation, dropping their blood pressure, right? Which then causes significant swelling because of that increased vascular permeability, right? So angioedema, remember, is the swelling of the tongue. Edema presenting as urticaria, so hives, rashes, airway constriction, and increased fluid in the airway, which is why if a patient is not getting any better with epinephrine, they need to be intubated, not just a king airway, but intubated, as that airway can completely close up due to that significant edema, that tissue swelling. All right, so if you look, So smooth muscle contraction, muscles start to contract, especially in the respiratory and gastrointestinal systems, causing potential for laryngeal spasm, larynx closing up, bronchospasm, significant wheezing, right, and abdominal cramping. That being the GI system. So when you have a patient with anaphylaxis and they have the laryngeal spasm and bronchospasm, if the laryngeal spasm is severe, that glottic open, that larynx closes up completely, right? We can help with bronchospasm by giving what type of medication can be administered for bronchospasm? I should have asked that question first. So what medications do we carry to help with bronchoconstriction or that bronchospasm? Yeah, albuterol. Albuterol, Duaneb, any kind of bronchodilator. All right. So you'll also see a decreased inotropic effect of the heart as well. So when combined with vasodilation, profound hypertension may develop. So now they're going to need epi, and they're also going to need fluids. So the release of leukotriene compounds the effects of histamines, which then further compromises respiratory status. You start seeing coronary vasoconstriction. Now we're losing our heart function. Worsening hypoperfusion, right? So now we're seeing decreased blood pressures even more, putting the patient into a distributive shock. And then the remaining chemical mediators that continue to worsen the situation. So we need to get, again, epinephrine and histamine blockers on board quickly, along with assisting with bronchodilation as well. All right, so clinical symptoms of anaphylaxis. You'll see the skin symptoms are often the first indication of anaphylaxis. The person will feel warm and flushed. You'll see pruritus or itching due to vasodilation and capillary leaking. So the area around the eyes are susceptible to this effect. Angioedema, swelling in the tongue, swelling in the hands and feet, urticaria, urticaria being full body hives, rashes. Respiratory symptoms as well are the most common complaints. You'll see dyspnea, tightness in the throat, chest, stridor, and hoarseness, which are often due to upper airway swelling in laryngeal and epiglottic areas. Again, this is why intubation and having the ability for a paramedic that has RSI capabilities, if they are that bad, to sedate and paralyze and put a tube in place before that area of the larynx and the epiglottic areas becomes so inflamed that you can't get airway in at all, and you end up having a medic doing a crike instead, which we try to avoid doing. Patients may also complain of a lump in the throat, bronchoconstriction and increased airway secretions, coughing or sneezing, and symptoms also may be slow or rapid. Cardiovascular symptoms are serious complications of anaphylaxis with decrease in cardiac output, which is complicated by vasodilation and increased capillary permeability. Decreased cardiac output and perfusion, ischemia, and potential for other cardiac arrhythmias. Tachycardia, or flushed skin, and hypotension are very serious complications of anaphylactic shock, or synonymous with anaphylactic shock. Blood volume, also moving from the intravascular space into the extravascular space, can also cause shock as well. So the body will not tolerate an acute blood loss of greater than 20% blood volume. That's where that distributive shock kicks in, and now we're starting to see shock-like symptoms. Gastrointestinal symptoms may also occur, particularly when the antigen is ingested. You'll see abdominal cramping, which is very common, but nausea, bloating, vomiting, what else? Abdominal distension, and profuse watery diarrhea as well may also be present. The central nervous system will also have symptoms as well, with headache, dizziness, confusion, anxiety, and a sense of impending doom. So anaphylaxis may affect 2 or more body systems. But there's 3 types of shock with this. 1, cardiogenic shock due to decreased cardiac output. 2, hypovolemic shock due to fluids leaking into the tissues. And 3, neurogenic shock due to the inability of the blood vessels to constrict. Right? So this can affect these and put these patients in one of these 3 different types of shock. Obviously, distributed shock being what's going on, but more specifically, cardiogenic, hypovolemic, or neurogenic. So as far as patient assessment goes, the assessment, problem identification, interventions within seconds are crucial. Remember I mentioned before, they have to be identified fast in order to make this determination, are we going to give this patient epinephrine? Suspicion for anaphylaxis must be high if any of the pertinent symptoms are present. Response to antigens may occur in a multi-step manner, with the immediate acute response being followed later by a delayed response. So just because you gave them epi and they started feeling better, it's still working. It could potentially still be going on in the system, which will then in turn later on, 10 minutes, 20 minutes down the road, go back into a full-blown anaphylaxis again, right? They need histamine blockers. They got to stop that release based on our receptors, H1, H2, H3 receptors in the body. Reactions can be acute or delayed. So acute reactions have a rapid onset and typically result in the most life-threatening situation. Delayed reactions may take hours or longer to manifest, and the response is not usually as exaggerated. In prolonged, persistent reactions, anaphylaxis symptoms continue over time from 5 to 72 hours. I've seen patients that have been on epi drips for days, intubated as well, to protect that airway, and also in turn reduce and cause vasoconstriction. In a biphasic response, the patient experiences an initial reaction, which appears to recover, and then experiences a reoccurrence of symptoms. So patients who experience an allergic reaction should be encouraged to seek medical attention to minimize the effects of a delayed reaction. So remember, they've been exposed, they've had an allergic reaction, they may have given themselves an EpiPen at home. It does not mean that they should not go to the hospital. A lot of times they'll say, well, I feel better, I don't really need to go. They need to get to the ER for further evaluation, blood drawn, and they can actually check those different mediators of that. So scene size up, consider scene safety, patient's environment, and what is the source of the reaction? I mean, we're not going to go into a bunch of killer bees everywhere, right? So we got to find ourselves into it and make sure we're safe. A respiratory problem reported by dispatch may be an allergic reaction. Even though they have respiratory distress, you sort of think, oh, maybe it's just going to be, a COPD issue. It could be an allergic reaction as well. We just don't know until we get there. Never enter a scene where more than one person has experienced the same symptoms with a similar onset, like an exposure, a toxin exposure. Consider the need for additional specialized resources, potential for trauma, and looking at the MOI or NOI. Severity of the problem will be indicated by the patient's presentation. How do they look? That's our general impression. Immediately begin airway evaluation and management. Respiratory symptoms should be swiftly assessed. A noisy upper airway may be the early sign of impending airway occlusion, EPI. Assess breath sounds for wheezing. If the breath sounds are diminished, as the patient's condition becomes worse, they'll become more diminished lungs. Listen for stridor as well, the upper airway blockage, right, with bronchoconstriction. Position an alert patient in a tripod position leaning forward. Initiate high oxygen therapy, high flow oxygen therapy. For unresponsive patients or those with an altered mental status who are in severe respiratory distress, assist ventilation using a bag valve mask and attach a high concentration of oxygen to the mask, to the bag. Palpate for the presence and quality of a radial pulse. How does it feel? Is it bounding rapid? Is it getting slow? What is going on with that? Basic life support measures and the use of automated external defibrillators, if necessary, if a patient is unresponsive and pulseless, right? Assess for signs of shock. Treatment include oxygen therapy, placing the patient supine, right, and preventing the loss of body heat. So again, we're still treating for shock, lying them down flat. Therefore, the heart doesn't have to work as hard to pump throughout the body systems, and preventing the loss of body heat. Definitive treatment for shock resulting in anaphylaxis is epinephrine. So expose and evaluate the skin for rashes, edema, moisture, urticaria, pruritus. Looking for the skin, look for what's going on. Immediately transport if the anaphylaxis is suspected or a mild allergic reaction is worsening, right? Or that delayed reaction. Treat respiratory distress or shock, then transport. Continue the assessment at the scene if the patient is calm and does not exhibit any signs or symptoms. If they have the signs and symptoms, back of the ambulance, let's get them to the hospital. We start our treatments. Investigate the chief complaint or the history of the present illness. Identify associated signs and symptoms using our sample and OPQ or STI. Like, have they taken Benadryl yet as part of one of the interventions? Check if any interventions have already been completed, and check if the patient has experienced a severe allergic reaction in the past. Have you ever been intubated for this before? Is one of the questions you should be asking. If they say, yes, I have, they've been in the ICU, this could turn out very bad for us. Do we need to have a paramedic on board to make the determination to intubate them or not? Ask about the previous exposure to common antigens as well. Then we're going to perform a physical examination. If the patient is exhibiting life-threatening signs and symptoms, perform en route to the hospital. Auscultate for abnormal breath sounds. Inspect the skin, again, for rashes, hives, or the source of the reaction. If it's a sting, we got to remove the stinger, right? So you got to look for what caused this and then try to find that source, because it's going to continue to get worse until the source is removed. Red hot skin is typical in early stages, suggesting a systemic reaction. Systemic reactions alters the mental status. So vital signs are every 5 minutes, if not less than that, to help determine whether the body is compensating for the stress. Are we seeing tachycardia, hypotension? What are we seeing? Assess baseline vitals, including pulse, respiratory rate, blood pressure, pupillary response, and oxygen saturation. With our monitoring devices, cardiac monitor may determine dysrhythmias associated with anaphylaxis, along with using end-tidal CO2. So monitoring pulse oximetry may alert you to low oxygen levels, but end-tidal carbon dioxide levels are more reliable than pulse oximetry in low perfusion states. Non-intubated patients, the waveform is more important than the numeric value obtained during capnography. Looking at that waveform is very important. We can tell if we start seeing that shark fin waveform, whether it be hyper or hypoventilation waveform, and we're looking at all those different types. That's why it's so important to get these patients on end-tidal. Right? The decision to administer oxygen to a patient experiencing allergic reaction should be based on a careful assessment of the patient's airway patency, work of breathing, and normal breath sounds on auscultation, and not solely on the pulse oximetry readings. Then we're going to work on our reassessment, conducted typically en route to the receiving hospital. Special attention should be given to any signs of airway compromise. So we're going to monitor the patient's anxiety and mental status, watch for signs of shock, and treat immediately. Identify any the severity of that reaction as well. Interventions would be the administration of epinephrine, and then checking the effect of the epinephrine once it's been administered. Check if the patient's condition has improved or if a second dose is required, and then recheck your interventions from there. As far as communication and documentation, when to contact medical control depends on your assessment findings and the urgency of care required. In some allergic reactions, you may use standing orders to administer epi, which all of you in New Hampshire have as standing order. For less severe reactions, contact medical control. Documentation should include signs and symptoms, but you should also clearly show care given and why you chose to administer the care you provided. And ensure the patient's ensure to record patient response and treatment in your narratives as well. So as far as emergency medical care goes, People with an allergic reaction are differentiating between the two conditions with similar symptoms. So a patient with allergic reaction are separated into two groups for treatment. One, the first group, patients who have um, signs of an allergic reaction but no signs of anaphylaxis. The drug of choice in this case is diphenhydramine, Benadryl. Right, IV is usually 25 to 50 milligrams, or it can be a PO administration as well. Again, these are paramedic drugs currently. It doesn't mean it's not going to change in the future for the advanced CMT. The second group of patients with signs of anaphylaxis who require 100% oxygen, epinephrine, and antihistamines, usually diphenhydramine. Those are going to be intravenous. Whenever dyspnea or signs of shock are present with signs of allergic reaction, you should administer epinephrine. Closely monitor the patient and provide rapid transport. For patients having a severe allergic or anaphylactic reaction, administer basic life support, provide prompt transport to the hospital, remove the patient from the situation involving the antigen or the antigen from the patient, maintain the airway, administer high flow oxygen via non-rebreathing mask at 15 liters per minute if the patient is breathing inadequately, and be prepared to assist ventilations with a BVM. Maintain a high index of suspicion for the potential for airway occlusion because of swelling and edema. Treat for shock, maintain circulation by administering isotonic solution at a wide open rate. Initiate 2 IV lines en route to the emergency department if the patient does not respond to epinephrine. Initially, administer 20 mL per kilo of isotonic solution rapidly over 15 minutes intravenously or interosseous administration if needed through an IO, and repeat as needed. All right, again, follow local protocol. If there is no response from the patient, consider calling for paramedic backup for the administration of a vasopressor in conjunction with fluid administration. So for us as paramedics in New Hampshire, it would be Levophed or norepinephrine. Or we can do push dose epi or epi drips. So find out which intervention has been completed before your arrival, what's been done, have they received any Benadryl, did they receive an EpiPen, and inform medical control of the patient's condition. So administering epi. Early administration of epinephrine should be a priority. The use of IM route if the patient shows evidence of airway or respiratory compromise or hypotension. Administration in the thigh, so lateral thigh, is preferred over the deltoid site for more rapid absorption because we have more musculature in our thighs than we do in our shoulders in the deltoid. Subcutaneous administration of epinephrine is unpredictable and may have delayed effects in the presence of shock. So this is why we do not do subcutaneous epi anymore. It's intramuscular injection in the right or left lateral thigh. Epinephrine can rapidly reverse histamine release. Rephrase that. Epinephrine can rapidly reverse the histamine-related effects of anaphylaxis. So many patients in AEMTs, EMS providers, carry epinephrine in the form of an EpiPen, right? But again, I have not seen EpiPens in a while in an ambulance, so know what your ready check and check kits look like and how to use them. Patients who receive epinephrine must be monitored closely for adverse effects. The use of a cardiac monitor, if available, to watch for dysrhythmias and reassess the patient's vital signs at least every 5 minutes. We're going to direct order for medical control required to use or help with a patient's auto injector. So in your books, skill 22-1 is how to use an epi auto injector, which all of you should be familiar with because that is an EMT skill. In a life-threatening situation, do not delay administration of epinephrine to expose the thigh, go right through the pants. As far as an EpiPen, it can be administered directly through the clothing. The injection time is 3 seconds. Take the steps to ensure the patient's leg does not move during administration. Hold it tight. Properly dispose of the injector and after administration in a biohazard container. Record the time and dose, the patient's vital signs, and any response to the medication. What is the dose for adult epinephrine? And what is the concentration of that? Okay, so you have 0.3 milligrams for the adult, and what concentration is it? 1 to 1,000. Perfect, awesome. Other allergy kits may also contain oral or IM antihistamines as well. So epinephrine and antihistamines work synergistically together. Side effects of epinephrine would be tachycardia, hypertension, anxiety, pallor, dizziness, chest pain, headache, nausea, and vomiting. So patients who do not exhibit signs of respiratory compromise or hypotension should not meet the criteria for a diagnosis of anaphylaxis and should not be given epinephrine. Provide prompt transport for any patient who is experiencing an allergic reaction or who has experienced poisonous envenomation or a bite. Continue to reassess the patient's vital signs en route and consider early transport if the patient needs resources beyond your capabilities. All right. So a little bit about management of insect stings. So they account for approximately 90 to 100 deaths each year in the United States. The stinging organ of most bees, wasps, and hornets is a small, hollow spine projecting from the abdomen. Some ants, especially fire ants, strike repeatedly, injecting a particularly irritating toxin or poison at the bite site, as you can see in this photo here of the foot. You also may, signs and symptoms include sudden pain, swelling, localized heat, widespread urticaria, and redness in light-skinned people. There may be itching and sometimes a wheal or a raised, swollen, well-defined area on the skin, as you can kind of see in the photo here. So applying ice sometimes makes wheals less irritating. Attempt to remove the stinger by scraping the skin with an edge of a sharp, stiff object, such as a credit card. Do not use tweezers or forceps. Squeezing may cause the stinger also to inject more venom into the wound. Once the stinger is removed, wash the area with soap and water or a mild antiseptic. Try to remove jewelry from the area before swelling begins. Get the jewelry off because the swelling gets in that area, like rings, wristbands, things like that, bracelets. Position the injection site slightly below the level of the heart and apply ice or cold packs to the area to hopefully reduce the swelling. Be alert for signs of airway swelling and other signs of anaphylaxis. Place a patient in a supine position if indicated and give oxygen if needed. Monitor the patient's vital signs and be prepared to provide further support as needed. And then obviously patient education. Educate the patients about prevention and self-preservation. Avoid how to avoid the antigen, notifying all health personnel of the allergy. When they get there, wear identification tags or bracelets, carry an anaphylaxis kit or an EpiPen, and report symptoms early so we can start getting treatments on board. All right. So why don't we take 15 minutes? We'll come back at 7:05. We'll do the last chapter, which won't take too long, and we'll call it for the night. All right. So I'll see you guys at 7:05.
This conference will now be recorded.
All right. So chapter 23, toxicology. All right. So AEMTs treat patients who have taken the drugs of abuse. Right. We know we've done this before. We've had many calls with this, whether they be legal, illicit, or illicit drugs, illegal. Illicit drugs, legal ones with like oxycodone, alcohol, whatever it may be, things like that. To heroin, ecstasy. The biggest ones now, ones we're seeing a lot of now, is fentanyl. Is in the field for overdoses as well now. A little bit of methamphetamine stuff, but we'll get more into that here in a moment. So poison is a toxic by nature. So no matter how it gets into the body or in what quantities, a drug is a substance that has a psychologic effect when given in the appropriate circumstances and dose. When a drug is taken in excess, a person is said to have an overdose. Overdose is a toxicologic emergency. And that's what we have to be able to pick up on, right? Learning our different toxidromes. So toxicology is a study of a toxic or a poisonous substance. So toxicologic emergencies would be intentional, like if poisoning an adult is commonly intentional, where in pediatrics, usually it's unintentional of the medication because they don't know any better. Unintentional would be like a medication dosing error or childhood poisonings, which are very common, right? So we get a lot of times we'll respond to a home where they've taken too many of their medications by error, or especially with the elderly where they take their medications more than once because they forgot they actually took them, things like that. So we got to pay attention to what we have and also investigate these types of situations where we look at our pill bottles and looking at our toxidromes that I talk about. And I believe I covered toxidromes I did. So we talked about toxidromes a little bit as well during our last practical session for the last scenario. We talked about different potential signs and symptoms that would indicate a specific type of overdose. So they can be found in the nature in the workplace. So the nature would be like wild mushrooms, different berries that are out there that are very poisonous as well. So a lot of things that happen within the nature of toxic environments. In the workplace, often is not identified until an exposure has actually occurred. So cancer from like PCBs or things, or asbestos as well, different things that people could come in contact with for the workplace stuff. Unintentional would be like result of neglect or oversight. Chemical or biologic warfare, which we covered already on Wednesday night. So intentional poisonings or overdoses may occur during crimes, right? So like roofies, for example, a date rape drug used to facilitate sexual assault, or knockout drops, which are used to commit assault. Pharmacologic agents are also used in homicide as well. So again, you may come in contact with these, and depending on where you work, or the type of, or I say where you work, but the demographics of where you work in, these may become common. So kind of pay attention to those. So don't hesitate to call poison control. They actually recommend that anytime you have any kind of ingestion of some sort, if it doesn't belong there, call poison control. The helpline is 1-800-222-1222. This should be in your phones. If you don't use your personal phones at work, then it should be in a work phone with the ability to contact them. This will give information on ingestion, its toxic potential, and steps to negate its effects. Access to information about all commonly used medications, chemicals, and substances that may be poisonous. Some mobile medical reference apps, such as Hippocrates, will also assist with pill identification. Poison Control also offers online triage tool and mobile device app called Web Poison Control. So there are different things that are out there that you can utilize, but the usage of Poison Control, one, helps them keep around so they don't go out of business, which can happen if they're not utilized. They can shut down different centers and make you have more wait times to be able to get a hold of somebody. As well as they give you a lot of information, also treatment protocols, looking for cardiac monitoring, different kinds of antidotes you can administer in the field. So there's a lot of information. And they also notify the receiving hospital with a printout, or they speak with a physician on what's coming in, what poison, so they can start prepping, working with poison control. So it's very important to have. So the pathophysiology, routes of absorption, okay, ingestion, inhalation, injection, absorption, right? And the ways you can enter the skin. Those are the four primary methods of entry. Each method entry is unique and also has, and so is the rate at which a given toxin is absorbed into the body. So we know that injection, right, inhalation works faster than versus ingestion or absorption, right? Inhalation or injection right into the vasculature versus right into the lungs will have a faster rate of signs and symptoms that you're going to see in the field. So the combination of the amount of toxin and the relative speed at which it is metabolized determines its effects in excretion rates. So poison by ingestion were the most common sources of medications around the home or household chemicals. This may produce immediate dangers to tissues and effects may be delayed for several hours, depending on what type of ingestion you had. So the effects occur immediately with ingestion of caustic substances. Other poisons must also be absorbed into the bloodstream first. So indicators. Plants with partially chewed leaves or missing berries. Stained fingers, lips, or tongue. Empty pill bottles from your recently filled prescriptions. You have to look on the prescription to see the quantity, how often it is taken, and when it was filled to determine how many pills should be left in that bottle. Patient complaining of sudden onset of stomach cramps with or without nausea, vomiting, or diarrhea may have an ingestion-related problem. Entry of toxins by oral routes take longer to be absorbed by the body. So little absorption occurs in the stomach. Absorption occurs mostly in the small intestines. So managing poisons by ingestion focuses on removing or neutralizing that poison before it enters the intestine. So it's in your stomach and before it processes. What is one medication for the National Registry that can be administered to help remove some of this, depending on the type we're dealing with? What is one medication? So charcoal. Yeah, exactly. So some emergency services may allow AEMTs to use activated charcoal as an alternative treatment. All right, a lot of states are actually getting rid of this because it's really never getting used. Activated charcoal comes in a suspension that binds to the poison in the stomach and carries it out of the system. More effective and safer than a syrup of Ipecac. So a lot of these have something called sorbitol in these. So it's a mixture that you mix with it, or it already has it inside, and that will cause you to go through defecation and push defecation versus just vomiting. One of the things you really want to make sure of, though, is that you don't want a patient vomiting back up a caustic substance, right? That could cause more harm than good to the airway, to the esophageal tract, into your airway, right? The oropharynx. Administration carries the risk of severe pulmonary injury if aspirated. Activated charcoal is, as it says, it's charcoal in a liquid form. Right? They drink it like a slurry. They mix it up, they drink it through a straw, or we can administer it, as you can see. I don't know if you can see the tip. So you guys see the tip here, right? So that's my poor excuse for an arrow, right? So this area here can be utilized to either drink, administer orally that way, or those fit really well into an NG tube or an OG tube that is placed, usually NG tubes that are placed at the hospital, or a paramedic can insert one in the field. So poisoning by inhalation are the most common sources of home medications, household chemical products. Can only occur if a poison is present in the surrounding atmosphere. If it is, do not enter the hazardous environment. Call for resources, specialized protective equipment like SCBAs. In toxic environment situations, you are likely to encounter more than one patient at an emergency scene. So try to give me one situation where a toxic inhalation could be present, and what could that toxic substance be? All right, yeah, exactly, CO. Right, yeah, smoke from a fire. Right, exactly. So inhaled toxins quickly reach the alveoli, right? So what's so important about the alveoli again? What's so important about the alveoli when it reaches that? Gas exchange, exactly, right? We don't want to inhibit that. So almost instant access to the circulation system, right? So it goes in, gas exchange happens. So that bad gas is coming into the lungs, right? Down the respiratory tract, into the alveoli, and then getting into the bloodstream because now it's being carried by red blood cells. The red blood cells do not know the difference between carbon monoxide and oxygen. They just attaches to it and it gets transported through the system. Okay, that's why it's so important when we have a patient who has had potential carbon monoxide poisoning is high flow oxygen to replace the carbon monoxide that's in the system. So the first consideration is scene safety. We should make sure we have specialized personnel to remove the patient. Please do not go in. Patient's clothing should not be removed during this process, or should be removed during this process. That should be removed. Do not administer emergency care until the patient's clothes have been removed, especially if they have an airborne type toxin that could be all over there. Because now you're going to have it in their clothing, and you bring it in the back of the ambulance, and now it's off gassing into the ambulance. They need to be stripped down to trauma naked to make sure that, and then cover them back up with blankets. Or if you happen to have a gown in your ambulance, I know I carry gowns. I believe we usually leave them on my stretcher for that to be able to take a patient's clothes off and put a gown on them. Obviously easier for 12-lead capabilities and other things as well. And they're going to have a gown put on in the hospital, so it works out well. Wide range of symptoms and signs and symptoms, many of which are unique to the toxin involved. Right, we'll cover more of those later. So, and we'll also cover more of this stuff in depth on Sunday as well. So tape the containers, bottles, and labels or pictures of them for the toxic substance with you to the hospital, so that way the other physicians can see it. Often patients use inhaled poisons to commit suicide, such as when a person sits inside a vehicle with an engine running or an enclosed garage. A recent variation of the use of automobiles for suicide, called chemical suicide, involves people using a tightly sealed vehicle as a type of gas chamber. So signs of chemical suicide would be taped or sealed windows, locked doors, posted warning signs, a suicide note, empty chemical containers, or an unusual odor. The scene often contains clues about the identity of the toxin as well. So clues at the scene, assistance of poison centers, and direction for medical control drive that treatment plan. So treat hypoxia immediately. Ventilations, BVM, oxygen, high flow. And establish vascular access, pulse oximetry. Keep in mind, it may not be as accurate, but we can also check perfusion with end-tidal CO2 and call for paramedic backup early, right? I was going to pick on Harrington, but he's not online right now. Poisoning by injection, usually the result of a drug abuse. Signs and symptoms can vary greatly depending on what we have, depending on what they're using for a drug. So in general, injected poisons are impossible to dilute or remove. Quickly absorbed into the body and cause intense local tissue destruction. So if you suspect rapid absorption has occurred, monitor the airway, high flow oxygen, be alert for nausea, vomiting, protect that airway. If they're nauseous, give Zofran. Right? Remove jewelry from the areas around the injection site if swelling does occur to prevent it making its own tourniquet. Prompt transport and take all containers, bottles, and labels with the patient to the hospital. Bites and stings are considered poisoning by injection. Organophosphates and pesticides are often the most serious. Corrosive substances damage the skin, mucous membranes, or eyes. Other substances are absorbed into the bloodstream through the skin and have a systemic effect. Distinguish between contact burns and contact absorption. How can you tell if someone has an organophosphate exposure? Perfect. All right. So signs and symptoms: history of exposure, liquid or powder on the patient's skin, burns, itching, irritation, redness of the skin in light-skinned people, and odors typical of the substance. So avoid contaminating self or others. Remove irritating or corrosive substances from the patient as quickly as possible. Cut off all clothing that has been contaminated. Never pull clothing over a patient's head, right? You should never flush off dry powder either, as that could activate a chemical reaction. So we want to make sure that we're not applying water because it's going to be a water reactive chemical, right? As you can see in this photo here, utilizing a nasal cannula to flush out both eyes. This is perfectly acceptable, utilizing a bag of fluid with a pressure bag to push the fluid through to flush out the eyes, as the liquids will then drain, as you can see here, downward direction on both sides, right? If you only have a single flush, you're not using a nasal cannula, turn the patient either on the right side or left side, and always flush the downsided eye, right? So if this patient was turned over onto their left side, we would flush that left eye so the chemical drains out, not into the other one that may not be affected, right? When a large amount of material has been spilled on the patient, flooding the affected part for at least 20 minutes may be the fastest and most efficient treatment or effective treatment. If the patient has a chemical agent in the eyes, irrigate the eyes quickly and thoroughly. Many chemical burns occur in industrial settings, so trained people will usually be able to be there to assist you. Do not try to neutralize the substance with other chemicals. Brush off as much as you possibly can that the material is a solid, and then immediately wash off the substance with plenty of water. Obtain material safety data sheets, or now called SDSs, because of the whole global harmonization stuff, and transport them with the patient. This helps us with our treatment plans. Always provide prompt transport and route continue irrigation and provide oxygen if possible. Look at the app called Wiser. I mentioned that before as well in other presentations. Very important information on medical treatments are also listed in that as well to help you, especially if you don't have access to cellular, I should say cell towers and have service on your phone. Those apps are usually downloaded onto the phone itself and help you with some treatment plans as well, as long as it's within your scope of practice. So understanding and using toxidromes. Toxidromes are very important. Many drugs result in a similar sign and symptom, and a toxidrome or a toxic syndrome is a syndrome-like symptom of poisonous agents. So we'll go over those here. Right. So many toxidromes are produced by stimulants, opiates, sympathomimetics, sedative hypnotics, cholinergics, and anticholinergics. Right. So table 23-2 lists common signs and symptoms of these poisonings. Right. So tonight, when the class is over, I will email you a toxidrome sheet that I made that you guys can utilize. Right. And it'll be very helpful when determining these types. Going over, one second here. Stand by 1 second. See if I can bring that up really quick. All right, so kind of go over some of these with you guys together. Oh, there we go. All right, so we're gonna go over a couple of these here that are looking at the different toxidromes. If you guys want to take notes or whatever it may be as well. So we look at cholinergics. So cholinergics would be like organophosphate poisoning. We talked about bradycardia, constricted pupils, looking at sludgem or dumbbells. So everybody has heard of sludge or sludgem. Dumbbells is defecation, urination, meiosis, bradycardia, emesis, lacrimation, lethargy, salivation, right? So kind of very similar to sludge or sludgem, right, as different options we utilized. Opiates, there's 3 things we look for opiates. What are they? For the toxidrome for opiates. What are 3 things you look for opiate overdose? Pinpoint pupils. Yep. There's one, right? Decreased respirations, and the last one would be pinpoint pupils. I'll give you lethargy, altered mental status. Right. So altered mental status, decreased respirations, pinpoint pupils. Those are the three things you look for. Right. Anticholinergics. Right. So anticholinergics would be something like antihistamines, antispasmodics, anti-Parkinson's, bronchodilators, smooth muscle relaxants, and atypical antipsychotics. Like so, antihistamine like Benadryl, antispasmodics, Donatol. Anti-Parkinson's would be like Artone, be the medication like that one there. Let's see, bronchodilators like Atrovent, smooth muscle relaxants like Flexeril. Atypical antipsychotics would be like Seroquel or Risperidol. Right, we look for a series. I like to call it the Alice in Wonderland theme, but hypertension, dilated pupils, tachycardia, skin is hot, dry, and red, altered mental status. So the way I like to put it is hot as a hair, dry as a bone, red as a beet, mad as a hatter, blind as a bat, and seizing like a squirrel. Right. So those are the things that we look for in anticholinergics. Right. Another one is something called tricyclic antidepressant or TCA. Right. So for us to be able to treat this, you're going to require a paramedic because it has to be sodium bicarb, 1 milliequivalent per kilogram per treatment. But to find it, to pick up on it, we use something called a SALT, S-A-L-T acronym. The SALT acronym, S stands for shock, A stands for altered mental status, L stands for long QRS interval on the EKG, and T is terminal positive deflection R wave in AVR, looking at an EKG strip. Right? And to see AVR, you're better off doing a 12 lead. Right? So terminal positive deflection R wave. As far as sedative hypnotics, we look for altered mental status, normal vital signs, normal pupils, late stages is respiratory depression, and then our sympathomimetic medications would be dilated pupils, hypertension, sweaty skin, tachycardia. So some examples of sympathomimetics and epinephrine, right, would be cocaine, methamphetamines, and bath salts. Usually patients are on sympathomimetics, like bath salts, cocaine, any kind of methamphetamines like that, require some kind of administrative medication of a benzodiazepine, which again, you need paramedics if they are completely combative, or a high dose of ketamine. Right? So that kind of goes over some of the common toxidromes. So if you see these series of events, looking at what we just talked about, we see those series of signs and symptoms, that can indicate what specific type of medication was taken, whether it be a stimulant, opiate, or opioid, sympathomimetic, sedative hypnotic, cholinergic, or anticholinergic. Again, if you go to 23-2 in your book, you'll be able to see more of that. I did make a handout that I can give to you guys. I sent through email. It's a one-page PDF form of the toxidromes as well for review. So when on Sunday, when we start doing scenarios again, I can almost guarantee you that you're going to see toxic substance inhalation or toxic substance scenarios where you're going to have to identify the toxin and which type it is. So I'll send that out to you guys tonight. Or I can just print them off for you on Sunday, which is fine too. So overview of substance abuse. So an area of medicine dealing with drugs of abuse is highly challenging. Uncertainty about the prevalence of the problem and continual evolution of that substance. So we talked about, like, for example, fentanyl. Started off as fentanyl, then it went to carfentanil, to all the just different derivatives of that medication, making it more and more potent because fentanyl, people are now starting to build up that tolerance and they need something stronger, right? Heroin was the big thing for the longest time, and now we're just seeing straight fentanyl. Heroin is almost non-existent, right? I said almost. It's still out there. People still use heroin, but again, we're seeing more of the fentanyl usage now, going into those different subclasses of fentanyl than we ever had before, right? So that's what makes it challenging, right? So self-administration or illicit substances in a manner not in accordance with the approved medical or social practice. All right, somebody give me an example of a natural hallucinogen. Okay, mushrooms. All right, excuse me, nutmeg is also a natural hallucinogen as well, right? So again, there are things out there, whether it be food products or whatnot, that will actually serve as a different use, overdosing, or trying to get that high. Another one is Mucinex DM. So the product in the DM, not the Mucinex itself, the DM part of it, is also a hallucinant, or also can get you high as well, but with higher dosing. Yeah. So you mentioned pop. Sorry, I just saw that there. So you mentioned poppy seeds. In order to even register on even a drug test, um, you would have to have, I don't know, it's like 80 or 90 poppy seed muffins. I don't know, it's a high amount of numbers of poppy seeds you would have to actually take in to be able to have anything register and actually get high off of. But you're all right though. Poppy seeds though are what makes the opiates. So that is 100% correct on that too as well. So society's definition may have little relation to potential harm of a substance. So like I said, the cultural variation is what's considered substance abuse. So a lot of times they see something and they'll change it to not its intended use as well. So one of the other ones that I've seen a lot of as well is speedballs, where you have that the upper and that I mean the upper mixed in. So like heroin or fentanyl mixed in with like epi or cocaine, right? So you see that variation. Right. So the other one that I've seen too as well, I'm just reading some of the notes here on this as well, is marijuana. So obviously now it's becoming legalized, but it's what's mixed in with it, whether it's laced with something different or whatever, that is not legal, right? So we're seeing that as well. And it's something different. We've seen things laced with something different, whether it be through inhalation or injection or whatever it may be. Crocodile is another one with petroleum products is with this. So there's a lot of different potentials that are there for that. You just got to pay attention to what the new things are out. So like if I get notices or whatever, I'll try to send them out to people as well. I don't get as many as I used to get, but having that notice and doing research of what the new is will help us determine as well how we're going to start different treatments to be able to pick up on what we have. Because if you pick up a toxidrome and you give the wrong medication for treatment, it can actually do more harm than good. So you have to be able to pick up on that. All right, hold on 1 second, guys. I'll be right back. Be like a minute. All right. So drug abuse is any use of a drug that causes physical, psychological, economic, legal, or social harm to the user or others affected by the drug or the drug user's behavior. Habituation is a psychological dependence on a drug or drugs, which may include psychologic tolerance. Physical dependence is a physiological state of adaptation to a drug, usually characterized by tolerance to the drug's effect and a withdrawal symptom if the drug is stopped, especially if it is stopped abruptly, which you also may come in contact with, especially when you're going to different rehabilitation homes or centers. Psychological dependence or emotional state of craving a drug to maintain a feeling of well-being. Tolerance is a psychological adaptation to the effects of a drug such that increasingly larger doses of the drug are required to achieve the same effect. They've built up that tolerance. Withdrawal syndrome is a predictable set of signs and symptoms, usually involving altered central nervous system activity that occurs after the abrupt cessation of a drug or after rapidly decreasing the usual dosage of a drug. Drug addiction, or the chronic disorder characterized by compulsive use of a substance resulting in physical, psychological, or social harm to the user who continues to use the substance despite the harm. An antagonist counteracts the action of something else. So a drug that is an antagonist has an affinity for a cell receptor and prevents the cell from responding. So give me a medication that we carry that's an antagonist. Yep, Narcan, exactly. Synergism is the action of two substances in which the total effect is greater than the sum of the independent effects of the two substances. So drug abuse occurs in all ages or all age groups and social levels. Why are you not changing? All right, so proceed and size up for a toxicologic emergency, determine the nature of illness or mechanism of injury, number of patients, need for resources, whether spinal mobilization is required, PPE, and then patients who have taken an overdose may be extremely dangerous, whether they be unresponsive to completely whacked out to the point where they're a harm to other people in society. Look for clues at the scene. So medication bottles, alcoholic beverage containers, syringes, or other drug paraphernalia, unpleasant or odd odors, the presence of a drug laboratory like a meth lab, things like that. So if you see any indications, take note. If it's something that is going to harm you, get out. Begin with a general impression. Do not be fooled into thinking that a responsive, alert, and oriented patient is in a stable condition. ABCs and ensure the patient has an open airway, adequate ventilation. We're going to assess the patient's circulatory status. We're going to assess the pulse and skin condition. We're going to check for bleeding. We're going to assess for disability and identify any additional corrections or conditions. We're going to alterations in ABCs or poor general impression or indications for immediate transport. Right. So a delay on the scene is rarely indicated. So consider decontamination of the patient before transport, depending on the poison that the patient was exposed to. Some industrial settings have decontamination stations and antidotes available on site. After completing the primary survey, begin obtaining the history, OPQRSTI. So remember, what's been done, interventions. I keep mentioning that because OPQRSTI is something that's new compared to what the old school EMS providers have learned, OPQRST. If the patient is responsive, begin with an evaluation utilizing your sample history, and then events leading up to injury or illness is very important of what they took will help determine how we're going to treat this patient. For the unresponsive, attempt to obtain history from others, friends, family members, medical identification jewelry, or cards in the wallet. With the sample history, ask the following. You need to know what is the agent, when was the poison ingested, injected, absorbed, or inhaled, how much was taken, injected, absorbed, or inhaled, what else was taken with it, over what period did the patient take the substance, so how long has it been going on for, has the patient or a bystander performed any intervention, has the interventions helped, has the patient vomited or aspirated, if so, how soon after the exposure and how much. Also ask what it looked like. Why was the substance taken? Was it intentional, unintentional? If the patient has overdosed on a prescription drug, take the pill bottle and remaining pills to the emergency department. If a substance was a commercial product, take the container and its remaining contents to the ED. If the patient ingested a plant, find out what part and take a sample of the plant to the emergency department for testing. If the patient vomits, save a sample of the vomitus in a clean, closed container. Over there, they can run testing. All right, then we work on our secondary assessment. We're going to focus on the area of the body involved with the poisoning or route of exposure. Right? We're going to manage life threats during the primary survey. And remember that the priority assessment and treatment goals as well. So remember, the primary survey is the priority assessment. Obtain vital signs. So many poisons produce an outward indication of the seriousness of exposure. So look for alterations level of consciousness, pulse, respirations, and blood pressure, and the skin as well. So reassess the adequacy of ABCDEs. My goodness. Record the vital signs again and compare them with the baseline set. We're going to start building our trending, okay? The trending is important. Evaluate the effectiveness of interventions. Repeat the assessment of vital signs every 5 patients for anybody that's consumed a harmful lethal dose, 15 for that stable patient. Why is it not changing? There we go. Interventions where treatment depends on the patient, what the patient was exposed to, route of exposure, and other signs and symptoms. So ABCs dilute the airborne exposure with oxygen. So high flow oxygen will dilute if it's airborne. Remove contact exposures with copious amounts of water unless contraindicated. So again, you don't know if it's water reactive or not, right? Unless you've done research on that on the exposure. Consider activated charcoal for ingested poisons. Continuously monitor the airway and contact medical control or a poison center to discuss treatment options, right? Honestly, talk to both. Even physicians with med control, they don't have all the answers to this stuff in front of them or having that ability to the reference materials that poison control centers have. So contact poison control and then med control and let them know what was discussed, right? Very important information. Once the primary survey, history taking, and secondary assessment are complete, contact med control to request necessary interventions. Report as much information as you have about the poison or chemical to the hospital, and if a safety data sheet is immediately available, take it with you, right? If not, then you can try to locate them on your phones too, right? Websites have them. All of them are all digital now. Actually, they all are. Ensure scene safety, standard precautions, perform an external decontamination, and remove tablets or fragments from the patient's mouth and wash or brush the poison from the patient's skin. So if you happen to see stuff in their mouth, then you remove with a gloved hand, right, to make sure they don't bite you. We're going to assess and maintain ABCs, provide oxygen, and perform assisted ventilations if necessary. Signs and symptoms of shock, we need to make sure we're treating that, and if approved by medical control or local protocol, give activated charcoal. Right, so not indicated for patients who have activated charcoal, or not indicated, that have ingested an acid or an alkali or a petroleum product. The last thing we want is have it come back up through. So have a decreased level of consciousness and cannot protect their own airway because it is a fluid that you're putting into the airway. I'm sorry, into their mouth. And if they're unable to swallow, then they can aspirate it into their airway. Right? Absorbs two ingested poisons, preventing the toxin from being absorbed into the body. The dose is usually 1 gram of activated charcoal per kilogram, so 1 gram per kilogram of body weight. Usually 50 to 100 grams for adults, 25 to 50 for children, 10 to 25 for infants. Right? Administration of activated charcoal carries with it severe risk of aspiration. So you really got to be careful when you're administering this medication. I can tell you that I've been in this field now for almost 24 years, and I've given activated charcoal maybe twice. Right? I think maybe 2 times, at least once, but not more than 2. Side effects would be black stools, nausea and vomiting, and possible airway problems. Alcohol is the most widely abused drug in the United States and around the world. Alcoholism is a state of physical and psychological addiction. The 4th leading cause of death in the United States, and alcoholics tend to have a chronic malnutrition and fall frequently. Alcohol is a very powerful CNS depressant. Induces sleep, dulls the sense of awareness, slows reflexes, and reduces reaction time, and causes aggression and inappropriate behavior and a lack of coordination. So medical problems associated with alcoholism, like head trauma, toxic reactions, or uncontrolled diabetes. So patients that are alcoholics, make sure you're checking your blood sugar on them if they're altered. There could actually be a hypoglycemic event as well. Death from respiratory depression and or aspiration of vomitus or stomach contents, like while they're sleeping or they're passed out drunk, and they vomit into their airway and take it in that way. A person with alcoholism is considerably more prone to many serious illnesses and injuries, like liver damage is the most common, like hepatitis or cirrhosis of the liver. Increase in incidence of pancreatitis, development of erosive gastritis. One of the big ones as well with severe alcoholics is going to be your esophageal varices as well, to add to that list. And those are like a bloodbath that they actually open up. It's like basically it's hemorrhoids of the esophagus, and they open up and bleed everywhere, causing significant blood loss and significant airway compromise. Atrophy of the cerebrum resulting in permanently reduced mental function, increased risk of breast and colon cancer as well. And if an intoxicated patient is unresponsive, treat as you would any unresponsive patient. As always, first establish and maintain the airway. Suspect internal bleeding if a patient appears to be in shock and withdrawal symptoms as well. Seizures usually occur within 12 to 48 hours. So benzodiazepine is going to be the treatment, so call for paramedic backup early. As far as treatment for DTs, delirium tremens, keep the patient calm, administer oxygen, establish vascular access, and manage hypotension. Reassess breath sounds, and maintain a dialogue with the patient, right? DTs are very dangerous. Delirium tremens can kill somebody, right? So you need to make sure you're paying very close attention to what's going on. Right. Any questions on alcoholism? No. Again, we deal a lot with this, and depending on where you work, you might even see more. So kind of keep that stuff in mind, that's all. Opiates and opioids, right? Drugs that act as a central nervous system depressant, there's two major divisions. An opiate, which is a natural drug derived from the opium or poppy plant, right? An opioid is a non-opium derived synthetic. So give me an example of one versus the other. What would be considered an opiate? Okay. Would morphine be considered an opiate? Do you guys consider morphine as an opiate? So morphine is natural, right? So what about fentanyl? Is fentanyl natural? No, it's not. It's man-made. It's not being considered an opioid. All right. So they're both illicit therapeutic agents in illicit substances. So examples, we talked about morphine, codeine, heroin, fentanyl, oxycodone, meridipine. Some of these I haven't even really heard of before either. But we look at all these different ones, opiates versus opioids. So again, like we talk about morphine, heroin, all these medications are all natural from opium or poppy plants. Does it make a difference to us in the field, though, honestly? Whether they overdose with fentanyl, morphine, heroin, oxycodones, doesn't really matter what they overdosed on. What do you think? Any thoughts? Okay. PPE precautions and dosages. Okay. But is treatment going to be the same for the most part? Yeah. And the treatment to this, for the most part, yes. Yeah. The treatment's going to be Narcan. The question is do we carry enough? Do we carry 40, 50 milligrams of Narcan, depending on what they overdose on? And that's going to be the question, right? I've transported patients in the interfacility world on Narcan drips before, that it was that bad. Intubated, on a ventilator, sedated, on Narcan drips because the opiate was so bad in their system. All right. So there's potential out there for it to be worse. Right. So opioids produce three major effects of the CNS by binding with the receptor sites in the brain and other tissue. Readily absorbed from the GI tract, but can also be absorbed from nasal mucosa or lungs. When taken oral, the effects of these drugs are lessened compared to when the effects are given parenterally, so intravenous. When heroin passes through the liver, it is metabolized into acetylmorphine, which continues to exert narcotic effects that may outlast the effects of Narcan. Again, if you give Narcan, and Narcan wears off, and the patient runs off, you might go back to him again later on being unresponsive because it stays in the system longer than Narcan does. It takes older adults longer to metabolize morphine. So an allergic phenomena may also rarely occur with opioid use as well. Morphine and heroin produce an impressive dreamlike state. Shortly after injection, the user will appear to pass out despite being quite lucid. So classic presentations of opioids feature cardiac arrest, seizures, constipation, right? Coma, vomiting, pinpoint pupils, hypertension, respiratory depression. So we mentioned this. Constipation is a big one, okay? So when you get called, I'll circle this if I can with my screen here. If you get called to a residence with someone who has severe abdominal pain, ask them, are you taking any pain medications? Because opiates can cause that constipation. And I'm telling you, when I talk about constipation, severe blockage to the point where it's like so dried up it doesn't even come out. And the doctors have to do digital impaction with their fingers going in to pull out most of it before they put an enema inside. Usually it's done with warm milk and warm molasses mixed together into an enema vial, and they just shove it in and we squeeze it inside to break stuff up. Yes, molasses and you make cookies with, and warm milk. So those two together are phenomenal enema to be administering. Nothing you would do as an AEMT in the field or know that you would want to. But again, the constipation stuff is very important to pick up on. So if you have someone who's constipated, ask them, do you take opiates for pain? Right? Or do you abuse opiates? Doesn't matter either way. It could literally cause them some significant pain. Right? And we don't want to have any kind of this blocked bowels or obstructive bowels that can cause bowel necrosis. So Narcan reverses the effect of opioid overdose. That's the plan. Our dosage, so this can be administered either by IV line, intranasal, or intramuscular. Intranasal works very, very well. Okay. Our dose is going to be 0.4 to 2 milligrams. May precipitate withdrawal symptoms resulting in violent behavior or seizure activity, which is why we don't want to push the full amount right off the bat. Your goal, your objective for a patient who has overdosed on an opiate is to help maintain respiratory status, not wake them up. Right? Let them wake up on their own. Right? And give just enough Narcan to meet respiratory drive. Right? The acute opioid reversal may lead to vomiting and aspiration as well. So this is why we don't want to push it fast. It should only be used when the patient has agonal respirations or they're apneic. So if they're still breathing, right, give a little bit of Narcan, right, not to keep them alive. If the patient goes into cardiac arrest, follow the algorithm shown in 25-3, right, and you guys all learned ACLS within your scope of practice. If the patient does not respond to naloxone, it is possible the person may have a mixed bag overdose. Okay, or they may be on an opiate like carfentanil that will take 20 to 30 milligrams of Narcan to even kick in and work. Right, so the patient is taking multiple drugs which are not opiates and will not respond to naloxone, or the patient needs a subsequent dose. Remember that the patient may have other underlying chronic illnesses and conditions like hepatitis, HIV, AIDS, malnutrition, sepsis as well. So medications taken for these conditions may interact with opioids. So document whether ingestion or intention was intentional or accidental and how much was taken and what was taken. Document whether the patient has vomited since the ingestion. If take any pills or bottles to the hospital with the patient for any findings to receiving personnel and any illicit substance to law enforcement. I've had more patients come clean in the back of the ambulance what they were taking when we tell them that we're not law enforcement, right? So they don't want to get in trouble. We need to make sure we know what they took so we can make sure they don't die, right? We're not going to arrest anybody, right? We got to make sure they don't die. All right. Any questions on opiates? All right, let's get into the stimulants. So stimulants can be either swallowed, smoked, or IV injection. So there are a few drugs that are compared to stimulants in their abuse potential. So first-time users can become addicted within a few days. Once addicted, abstinence is unlikely to be successful. So taken orally, smoked, or via IV injection, the clinical presentation would be excitement, delirium, tachycardia, hyper or hypotension with a fast pulse, dilated pupils. As toxic levels are then reached, we started seeing psychosis, tremors, seizures, cardiac arrest, and hyperprexia. Cocaine is a naturally occurring alkaloid that is extracted from the erythrooxylin coca plant leaves. The street name for these would be blow, coke, stash, nose candy, snow, dust. Other ones, if you guys know of any more, feel free to throw them up on the chat. Right? But there's plenty of them out there. The local anesthetic, and it's also a local anesthetic and a CNS stimulant. Effects make cocaine one of the most, if not the most, psychological addictive drug. Quickly absorbed across the mucous membranes, applied topically, swallowed, snorted, or injected intravenously. May be mixed with baking soda and water and cooked or baked, like for crack cocaine. When snorted nasally, effects are felt within 1 to 2 minutes, and the peak effects occur within 20 to 30. When smoked, the onset effects are 8 to 10 seconds, and the high is more intense through the effects that, though the effects do not last as long. So when effects wear off, the user experiences a crash characterized by depression, irritability, sleeplessness, and exhaustion, which is what they call cocaine washout syndrome. All right, amphetamines include methamphetamines like ice or crank, MDA or Atom, MDMA, Eve or ecstasy, which have several legitimate clinical applications, like nasal decongestion, diet pills, drugs for narcolepsy, drugs for attention deficit disorder and attention deficit hyperactive disorders, ADHD and ADD, methamphetamines, which are low cost and long acting up to 12 hours, which are extremely addictive and a public health problem. Meth labs should be treated as a hazardous material incident. Are meth labs very large, or can they fit in your back pocket? Or could they be both? Justin is saying both. Everybody else agree with him? Rosa's got both. Right? Everybody's wrong with it. Both. I love it. All right. Meth labs can pop up anywhere. All right. So keep an eye out for that. Synthetic catacombs marked as or bath salts contain an active ingredient that is a pseudoephedrine or Sudafed reduction drug called methacatat. My goodness, I can't even speak today. It's similar to a methamphetamine knockoff. So bath salts are not as popular as they used to be. But for some of us older providers in the class, has anybody ever dealt with bath salts before? Justin, you want to unmute and kind of give us your experience with bath salts? Not you specifically, but how you treated a patient with
that. Long story short, I got my ass kicked.
Yeah.
About 10 of us to get him down.
Yep. So the drug of choice, okay, with bath salt overdose or bath salts in general is Versed. You can try Valium, you can try Ativan, right? Those are not going to work. All right. The drug you need is high doses of Versed. Versed works very, very well. So users snort, smoke, or ingest these drugs. All right. So they couple with intensity and long-acting effects of methamphetamine with the euthyroid effects of crack cocaine. The most serious side effects include agitation, hallucinations, and paranoia. Signs and symptoms of stimulant abuse: wide-eyed, thin as a rail appearance, nervousness or jittery movements, weak, long runs without sleep, inadequate nutrition, and increased paranoia. So complications associated with cocaine would be a lethal cardiac dysrhythmia, acute myocardial infarction, seizures, stroke, apnea, hyperthermia. So crack smokers may also risk pneumothorax and a pneumomediastinum. The clinical presentation for patients abusing amphetamines or methamphetamines is almost identical to a patient abusing cocaine, except that the effects last hours longer. So the use of synthetic medications like this or drugs is associated with significant paranoia, hallucinations, incredible strength, excited delirium, and other bizarre behaviors, to include tachycardia, diaphoresis, nausea, hyperthermia, which also may be present. So treatment for stimulants would be maintaining maximum oxygen saturation levels, prevent seizures with adequate sedation, monitor serial vital signs every 5 minutes, consider paramedic backup because you still have to have them for the sedation, and establish vascular access and manage hypotension, apply the pulse oximeter, right? Apply end-tidal carbon dioxide monitoring, transport the patient to the appropriate facility, and in severe cases of stimulant overdose, the patient may present with hyperthermia. So we're going to apply ice packs or a mist to the patient's skin. We're going to maintain peripheral perfusion with aggressive fluid therapy throughout resuscitation process. Remember that the potential for the patient to be emotionally or psychologically unstable. So contact law enforcement for support when you first suspect the possibility that violence may occur. Marijuana and cannabis compounds harvested in dried leaves and flower buds of the cannabis sativa plant, also known as weed, pot, dope, smoke, or bud. Over the past decade, many states have legalized the use of marijuana for medical use and some for recreational use. Usually smoked but can be ingested. One of the side effects: minutes when smoked and several hours when ingested. For onset, users have a distorted sense of time and space, and occasionally a feeling of unreality. So smoking marijuana results in bronchodilation and slight tachycardia. Right. Other other signs and symptoms include drowsiness, decreased short-term memory, diminished motor coordination, increased appetite, bloodshot eyes. So really, the treatment for this is really going to be supportive care, unless it's been laced with something else, right? And then if it's laced with, like, for example, fentanyl somehow, you're going to have to be able to treat that with the opiates. So you got to be able to pick up on the different signs and symptoms. That's why I keep bringing up the toxidrome, the series of signs and symptoms, to be able to determine what the patient actually has ingested or taken in. So, all right. So spice is a blend of synthetic cannabis, which is active substance, is sprayed onto a plant-like material for smoking, or sold as a liquid for vaporizing and e-cigarettes. Adverse effects are psychosis, hallucinations, tachycardia, vomiting, renal problems, and seizures, right? So the kidney issues. Obtaining a good assessment and forming a treatment plan can be challenging with this. Supportive care with fluids and airway maintenance is going to be important. And also, benzodiazepines are recommended for patients experiencing a seizure. So again, you need to get ALS. en route, paramedic level ALS, to administer benzodiazepines. Hallucinogens alter a person's sensory perception. Experiences involve hallucinogens are very markedly. So classic hallucinogens, all right, is LSD. So affects the senses rather than the changing psychological functions. Synesthesia crossing the senses can occur as well. With higher dosing, the effects of LSD can last as long as 12 hours, although 3 to 4 hours is more typical. The effects of LSD are tachycardia, mild hypertension, dilated pupils, and anxiety attacks. All right. So, like I said, mushrooms, among the most frequently used hallucinogen in the United States. Onset of symptoms and hallucinogenic effects last 30 minutes of ingestion, usually last about 4 to 6 hours. You start seeing it within the first 30 minutes. Signs and symptoms would be nausea, vomiting, mydriasis, mild tachycardia, mild hypertension. Seizures and hyperthermia may also occur. PCP or angel dust, relatively uncommon among young adults, typically smoked or snorted or injected, with slurred speech, staggering gait, tachycardia, hypertension, staring blankly for extended periods of time, and horizontal nystagmus are very common, the movement of the eyes. And also rigidity and especially grinding of the teeth prompt many users to resort to pacifiers in the effect to avoid pronounced jaw aches. Hallmark use includes mild body separation, related hallucinations, and violent outbreaks. So users have a high tolerance for pain and can also exhibit superhuman strength. Now, Special K, ketamine, is a similar in chemical structure to PCP. Most ketamine available on the streets is stolen from veterinary clinics, although the drug is increasingly being used in emergency medicine. So like I said, we carry in our drug boxes 1,000 milligrams of ketamine. 1,000, that's a lot of ketamine. It's colorless and odorless and commonly found in powdered form. Right, not ours. In the ambulance, they're supplied in a liquid form. Often mixed in a drink, although it can be snorted. Physically and psychologically addicting. Dissociative anesthetic, which is great for patients when they're in pain. I gave it to a patient one time for pain management, and they thought they were in a video game. Everything looked pixelated to them. So I've seen some interesting effects with these patients. In extreme cases, users will enter the K-hole, which involves an out-of-body experience, right? So long-term use can result in extensive problems with memory, conjunctive impairment, and the inability to properly speak or see. So the last one would be dried flower buttons of the peyote cactus. No currently accepted medical use in the United States. Profound vomiting occurs shortly after ingestion. The user may experience hallucinations, a distortion of time and space, and out-of-body experience. Physical effects: dilated pupils, increased heart rate, mild hypertension, and increased body temperature. So treatment is primarily supportive for hallucinogens. To limit sensory stimulation, routine transport for psychosocial support. For the patients who have used PCP or ketamine, secure the patient well, access or assess ABCDEs and manage for any life threats, administer oxygen therapy, and establish vascular access if the patient is receptive. Provide safe transport to the appropriate facility. With benzodiazepines may help calm an agitated patient who is experiencing significant delirium. PCP can cause violent and difficult behavior. So care for these users would be primarily supportive. To pay attention to the ABCs, oxygen therapy, vital sign monitoring, providing positive psychological support, providing safe transport. All right. With that being said, we're going to take a quick 10-minute break. We'll come back and we'll be able to finish up the rest of the presentation. So let's take 10 minutes. So it's 8:16 now. Come back at 8:25.
This conference will now be recorded.
All right. So sedatives and hypnotics. So sedatives reduce anxiety and calm agitated patients, right? Benzodiazepines, things like that. Barbiturates. We'll talk about those here in a second. Hypnotics help produce drowsiness and sleep. Excuse me. So barbiturates are sleep aids, anti-anxiety drugs, and seizure control medications, right? Like Keppra, things like that are used for seizure control. Combination of alcohol and barbiturates used frequently by people to attempt suicide, right? So what's happening if people are taking alcohol and barbiturates? What do you think is happening in the system? Yeah, complete system depression. Exactly. Oh, let me hit that button. My apologies. All right, so symptoms would be drowsiness, decrease, decrease. What's my train of thought here? Ataxia, mental confusion, and staggering gait, and decreased inhibitions. So as the dose increases, the patients become increasingly lethargic and demonstrate an increasingly lower level of responsiveness until they are unresponsive. Abrupt cessation in a long-term abuser will produce typical signs and symptoms of withdrawal syndrome. Benzodiazepines are commonly used to treat anxiety, seizures, and alcohol withdrawals. Ativan going to be one of the most typical for the alcohol withdrawal. Effects include sedation, reduced anxiety, and relaxation of strained muscles. So a person is likely to use other drugs and alcohol. A common clinical effect would be altered mentation, androgynous confusion, slurred speech, ataxia, and a general lack of coordination. So withdrawals from benzodiazepines may include tachycardia, confusion, and possibly seizures and then tremors. Withdrawal is rarely a life-threatening event with this. So care would be airway management is the first priority, paramedic backup, oxygen. For shock, rapid infusion of your 20 ml per kilo bolus. Up to 2 liters of bolus as normal saline may be needed. And there's a medication called flumazenil or Romazicon, which is available for managing benzodiazepine overdoses, although its use in the pre-hospital setting is rarely warranted. So New Hampshire, for paramedics, used to carry flumazenil, but it wasn't if they had a benzodiazepine overdose in the field, is that the paramedic gave too much, and they could use it to reverse what they did, right? Because flumazenil mixed with other medications can actually be very deadly versus it's a good use if you only have benzos on board. Activated charcoal is also a treatment option. Cardiac meds, antiarrhythmic, beta blockers, calcium channel blockers, cardiac glycosides, and angiotensin converting enzyme inhibitors. So antidysrhythmics for medications like amiodarone, lidocaine, those would be like your antidysrhythmics. Beta blockers, anything that ends in OLOL, like propanolol, labetalol, metoprolol, those are all beta blockers. Why is it important to understand about beta blockers and patients taking them? What can it hide? What can it cover up? Yeah, mass hypertension, but go the other one too, though. What else? What else would you see with shock normally? So tachycardia, right? So beta blockers also reduce heart rate as well. Calcium channel blockers would be more like diltiazem, things like that, and cardiac glycosides as well, and that would be digoxin, being a cardiac glycoside. With digoxin overdosing, you're going to see ice cream scoop J waves in the EKG. They'll also have a yellow vision for dig toxicity, right? So some things you need to pick up on in the field when patients overdose on certain medications you can see here. Angiotensin converting enzyme inhibitors, or what they call ACE inhibitors, or anything that ends in a PRIL, pril, like lisinopril, is an ACE inhibitor. And that helps the converting enzyme that helps convert angiotensin 1 into angiotensin 2. And many patients can take a combination of multiple medications that are there. So severe signs and symptoms of overdose would be hypotension, weakness and confusion, nausea, vomiting, rhythm disturbances, mostly common, be bradycardia or a heart block, headache, and difficulty breathing. So we're going to ensure a patent airway, provide adequate ventilation, administer high flow supplemental oxygen. Establish vascular access as well with interventions and antidotes are available if specific agents are identified. With hypotension, sequential fluid boluses of normal saline will also often bring the blood pressure to an acceptable range. Consider paramedic backup for advanced airway management and administration of vasopressors and contact medical control. Cardiac medication overdoses truly can kill somebody because of the effects of the different medications that are there. All right, so other medications, erectile dysfunction medications, are the most dangerous of the various drugs that increase sexual gratification. Viagra, Cialis, Levitra are contraindicated for patients who take nitrates for cardiac conditions. In these patients, erectile dysfunction medications may result in severe hypotension or total cardiovascular collapse, complete failure. With hypotension, repeated boluses of normal saline can increase blood pressure to an acceptable level. So if cardiac arrest occurs, follow local protocol. The other one would be TCAs, tricyclic antidepressants, which carry a high risk of intentional overdose. Common signs and symptoms would be altered mental status, dysrhythmias, dry mouth, blurred vision, and dilated pupils, urinary retention, constipation, pulmonary edema, as well as more serious toxic exposure with ventricular tachycardia, hypotension, respiratory depression, and seizures. The management for this, obviously, is getting paramedic on board, right? So they need to give sodium bicarb for this treatment. But for you guys, as AEMTs, call for the medic, high flow oxygen, vascular access. Charcoal may be within range to give with medical control, but you really need to manage that hypotension with sequential boluses of saline. Assess the blood glucose level, rule out any kind of head trauma, and monitor for agitation, violence, and provide rapid transport to the closest appropriate facility. Make sure you give them a heads up that you believe it's a tricyclic antidepressant overdose so they can start prepping for treatments. Like I said, the big treatment, other than monitoring airway management, is really going to be that sodium bicarbonate administration at 1 milliequivalent per kilogram. So MAOIs, sometimes used to treat depression, can precipitate a hypertensive crisis if taken in conjunction with trimine-containing foods. Triamine. My iPad's almost dead here. Put that in really quick. All right, so sometimes often are delayed, occurring 6 to 12 hours after ingestion, and in some cases, as long as 24 hours later. Early signs and symptoms would be hyperactivity, dysrhythmias, hyperventilation, and nystagmus. With increased levels of toxicity, chest pain, palpitations, hypertension, diaphoresis, and agitated or combative behavior marked with hyperthermia and hallucinations. So there's no antidote available. So establish and maintain airway management, oxygen therapy, IV access, cardiac monitoring, and the administer of charcoal if recommended by med control. Do not give syrup of ipecac, even though we do not carry it, we do not give it. We're going to treat hypotension with sequential fluid boluses. If a seizure occurs, call for paramedic backup for medication administration. So selective serotonin reuptake inhibitor, SSRIs, manage depression where patients may be asymptomatic. So they would include the following: nausea, vomiting, dysrhythmias, sedation, tremors, and possible dilated pupils. Agitation, blood pressure changes, seizures, and hallucinations. So for care for this, IV access, 12-lead monitoring, high flow oxygen, consider paramedic backup, and once again, you can call med control for a single dose of charcoal. Lithium, which is used for treating bipolar disorder, which is excreted from the body slowly. So the threat of toxic levels and overdosing is always present. Signs and symptoms are nausea, vomiting, hand tremors, excessive thirst, and slurred speech. At increased toxicity, ataxia, muscle weakness, and incoordination, blurred vision, and hyperreflexia. Patients may have seizures and become comatose as well. So management is mostly supportive. So we're going to establish and maintain an airway, administer high flow supplemental oxygen, and ensure vascular access. With hypotension, administer serial boluses of normal saline and transport the patient to an appropriate facility. Non-steroidal or NSAIDs are popular options for pain relief, fever control, and anti-inflammatory action. So most problems involve long-term use. So gastrointestinal bleeding and kidney dysfunction with chronic use, signs and symptoms, headache, altered mentation, behavioral changes, seizures, and bradydysrhythmias. Hypotension, abdominal pain, nausea, and vomiting as well. So care is usually supportive. So establish and maintain airway management. Again, hypotension with fluid administration, IV cardiac monitoring, and call for paramedic backup if hypotension persists. Right? So aspirin, over the counter, containing cause of toxicity, nausea, vomiting, abdominal pain, diaphoresis. Ringing of the ears as well. Pulmonary edema and acid-base disturbances. Severe toxicity may produce metabolic acidosis or combined with respiratory alkalosis and metabolic acidosis. There's no real antidote or antagonist available. There are some things that they can use in the hospital, but again, if they even have it available. Field emergency treatment, though, really is going to be same as before: airway management, oxygen, but put end-tidal CO2 on these patients as well. Acetaminophen is a well-tolerated drug with few side effects, so accurately estimating the time of ingestion. The antidote should be given fewer than 8 hours after ingestion, right? And this is a series of different dosaging that has to be administered. Management would be airway management again, high flow oxygen, establish vascular access, consider administration of activated charcoal, and transport. So GHB, frequently associated with sexual assaults, odorless and colorless liquid that has a salty taste, may not be noted when placed in a drink. Produces a profound hypnotic effect, along with disinhibition, severe passivity, and excuse me, and amnesia as well. Treatment focuses on the CNS depression and the risks associated with the patient being unable to protect airway. So again, airway management, oxygen, IV therapy, cardiac monitoring, and provide rapid transport, along with pulse oximetry and end-tidal CO2 monitoring. Organophosphate is a major component in many insecticides or pesticides. Similar performing compounds are used in nerve gases designed for chemical warfare. The treatment for this is 2-PAM and atropine, which we do not carry as AEMTs. We do have duodote kits, but those are meant for us specifically if we come in contact with the organophosphates. So rapid transport to the hospital, monitoring airway management, cardiac monitoring, IV therapy as well for organophosphates, utilizing sludge, sludgem, or dumbbells. Symptoms would be anxiety, restlessness, headache, dizziness, confusion, tremor, seizure, dyspnea, diffuse wheezing, respiratory depression, loss of consciousness as well. We already covered dumbbells and sludgem earlier. So if you have or an organophosphate potential, decontaminate, remove all contaminated clothing before initiating care, loading the patient into an ambulance. If you have this, notify the hospital early for further decontamination. Airway management, suction, administer high flow oxygen, vascular access, cardiac monitoring, paramedic backup, pulse ox and end tidal, and transport immediately. So the Mark 1 kit or the duodot auto injectors, those can be utilized. However, in the field for us, they were put on the ambulances with a non-funded mandate that was something that a lot of ambulances took off because they expired. So the non-funded mandate that was there. So they basically unmandated the duodot or Mark 1 kits to be on the trucks. But they were only used for us in case we got exposed to the nerve agent. So carbon monoxide, I mean, you guys all know what this stuff here is as far as carbon monoxide goes. One of the most common fatal poisonings produced by the incomplete combustion of an organic fuel. So poisoning may occur when a flue or ventilating system becomes blocked. There also be a method of suicide, major contributor to death at house fires, colorless, odorless, tasteless gas. The toxicity arises primarily from affinity of CO for hemoglobin in the red blood cells. So it attaches to the hemoglobin, thinking that it's oxygen, and transports throughout the body, causing us to have increased levels of carbon monoxide. And the true treatment for this is going to be oxygen therapy or ventilations. If they're unresponsive, they're going to have to go to a hyperbaric chamber to get the removal of carbon monoxide out of the system. Right, headache, nausea, vomiting are some examples of some of the side effects for this as well. So we have to make sure we're actually monitoring carbon monoxide in the system. By doing that, we have what they call like a RAD 57 or SPCO monitoring. Most cardiac monitors, I know that where I work, we have those on all of our cardiac monitors to be able to utilize. So again, something that's good is a monitoring device to kind of see how much carbon monoxide is in the system. As far as care goes, I mean, maintain airway, keep quiet, monitor, transport. We do not carry cyanide kits anymore. We used to carry cyanide kits in the ambulance, but for smoke inhalation, the problem is that they are very, very expensive, and they very rarely ever get used. So a lot of services have taken them off. They're thousands of dollars, if I remember correctly, per kit. As far as metals, lead poisoning remains the leading cause of chronic metal poisoning. Many may significantly hamper intellectual development in children. With inorganic lead, absorption usually occurs via the respiratory or gastrointestinal tract. Once in the body, approximately 90% of the lead is stored in the teeth and bones. Inorganic lead can also cross the placental barrier and negatively affect fetal development. So the half-life of lead in the bone is estimated 30 years. So most organic lead exposures occur in occupational settings. Encephalopathy is a major cause of mortality and morbidity with this. All right. So for treatment, identify the source of the lead, establish, maintain airway, IV cardiac monitoring, and do not provide fluid therapy unless hypotension is present and transport the patient. With iron, the toxic effect of iron exposure reflects the amount of elemental iron ingested. So gastrointestinal toxicity symptoms include abdominal pain and diarrhea. Systemic toxicity, hypotension, or shock from coagulopathy and vomiting blood. Patients are commonly in metabolic acidosis. Children typically remain asymptomatic with low-level iron exposure. So patient provide basic attention to the ABCs and transport the patient. So some miscellaneous substances like chlorine gas exposure is relatively common because of the worldwide use of chlorine compounds in the home and occupational settings. So signs and symptoms would be a burning sensation in the eyes, nose, and throat, slight cough, and more intense exposure to be chest tightness, choking, paroxysmal cough, headache, nausea, vomiting, diffuse wheezing, cyanosis, crackles in the chest, shock, seizures, and loss of consciousness. So what we need to do is remove the patient from the exposed area if you are trained to do so, and irrigate the burning or itching eyes with water, as well as any other areas of the skin that have come in contact with chlorine. Right? Remember, breathing problems, if you have multiple patients, treat them first. Cyanide is exposure can occur as a result of combustion and fire, industrial exposure, after ingestion of products that contain cyanide. Cyanide exposure blocks the utilization of oxygen at cellular level, results in cellular suffocation and death. Within seconds of cyanide was inhaled, within minutes or 2 hours if it was ingested. So patients may have an altered mental status and complain of palpitations, dyspnea, or a headache. Odor of bitter almonds on the patient's breath is highly suggestive of cyanide poisoning. Respiration is usually rapid and labored early on, then becomes slow and gasping. Rapid and threatening pulse, vomiting, seizures, and coma. Paramedic backup. We do not carry any medications for cyanide poisoning in the field at all. So transport rapidly to the hospital. Caustics or strong acids or strong alkalis are used in industrial, agricultural, or in the home. In most cases of exposure involve accidental dermal or ocular exposure. So oral ingestion of caustics is usually an intentional suicide attempt. So severe pain in the mouth, throat, and chest. Signs and symptoms are severe pain in the mouth, throat, and chest. Respiratory distress is most likely due to a soft tissue swelling in the larynx, epiglottis, or vocal cords. Establish access, cardiac monitoring, end-tidal CO2, SpO2, vital signs. For an eye exposure, continuous irrigation. If only one eye is exposed, do not contaminate the other while washing. So again, depending on which eye is exposed, turn the patient on their side of the exposed eye so you can flush it out. Methyl alcohol and ethylene glycol, so antifreeze as well. Patient may have severe abdominal pain, diarrhea, and belching, sometimes lasting for hours after the incident. These patients are going to become very acidotic. Their pHs are going to drop very low. It's also going to put them in renal failure, or kidney failure, sorry. And more of that, renal failure and liver failure as well. So again, this stuff can kill somebody with high amounts of ethylene glycol. So remove contaminated clothing, decontaminate the patient, ideally before placing the patient in the ambulance. Establish and maintain airway and ensure adequate ventilations. High flow oxygen, again, IVO2 monitor, end tidal. And administer normal saline boluses to treat any kind of hypotension. As far as food poisoning, like salmonella, norovirus, listeria, toxoplasma, these are 4 different pathogens that are the leading cause of food-related deaths in the United States. So consider when 2 or more people are sick at the same time in the same scene, right? So botulism as well for improper canning of foods. Toxins produce what they call in red tides. Red tides may contaminate shellfish such as oysters, clams, and mussels and produce life-threatening and fatal paralytic shellfish poisoning. So depending on the toxin, signs and symptoms may be several hours after ingestion or days or weeks later. So asking that patient last oral intake, but also if they have abdominal pain, what has your food intake been for the last couple of weeks? Would be a decent question to be asking these patients to find out if they have a true food poisoning, what they may have been exposed to. Gastrointestinal complaints are the most common: abdominal pain, cramping, nausea, vomiting, and diarrhea. With prolonged episodes of vomiting and diarrhea, hypotension, secondary to fluid loss, and electrolyte imbalance become likely. Right? So treatments for these patients are really going to be LR to give them that to help them remain that balance of the electrolytes they've lost. Respiratory distress or arrest can occur with botulism or paralytic shellfish poisoning. Treatment is supportive, so establish and maintain airway, high flow oxygen, IVO2, and monitor, end-tidal CO2 monitoring, and consider paramedic backup. As far as plants, few plants are poisonous, but some are most common are the ornamental shrubs and house plants. So most plant-related exposures involve children younger than 6 years of age. Some plants cause local irritation of the skin. Others affect circulatory system, the gastrointestinal tract, or central nervous system. So there's one called the dumb cane. It's a nickname because eating this plant can result in a person being unable to speak. In severe cases, edema of the tongue, angioedema, and larynx may lead to airway compromise. So the other one, the castor beans or ricin causes as well, which I talked about in one of my previous lectures here. Burning of the mouth and throat, nausea, vomiting, diarrhea, severe stomach pains, failing vision, kidney failure as well. So really, we need to get information from the Regional Poison Control Center, kind of asking them what's been going on and how it happened. So we're going to find out exactly what was eaten, find out what signs and symptoms, if any, of the patient has, as well as most plant-related exposures require no treatment at all. So we just need to kind of find out what they have, what they've gotten into, and what plants are poisonous or not. So the treatment for the poisoning would include ABCs, IVO2 monitor, assist airway ventilations, and prompt transport to the hospital. So as you can see, looking at the photos here, we'll go from left to right, top to bottom. So the diaphragm bachia plant is the one upper left-hand corner. The next one would be mistletoe. The third one over here. So this one right here, castor beans. This is called nightshade over here. Foxglove. Rhododendrons. Jimson weed. And then death camas. All different poisonous plants. The ones here, poison ivy, poison oak, pokeweed here, rosary peas. Those are very toxic as well. And then poison sumac. All right. With that being said, any other questions for the night?